Thanks for having me. So I'm going to talk to you about stereotactic brain radiosurgery. I do some stereotactic spine radiosurgery. Most of what the radiosurgery I do is for brain. I'm naming this or focusing on as this a bloodless brain surgery, although certainly one could argue there are other minimally invasive techniques like aneurysm coiling that are also bloodless. But I think a lot of the bloodless brain surgery that we're doing is this stereotactic radiosurgery. It is a very new technique. I mean, maybe been around 15, 20 years that it's really taken off, and I think is a critical technique for a lot of the brain disease we see, at the very least brain tumors, brain vascular malformations, and brain functional disease. So first is, what is stereotactic radiosurgery? So this is one definition, is a non-invasive technique to deliver a single high dose of radiation to a limited, well-defined target volume while avoiding nearby normal tissue and critical structures. Nowadays, people are defining this as treatments in up to 5 sessions. And this is really the short take of it. Radiosurgery is a stereotactic lesioning technique. It is a means of using precise technology and data about 3-dimensional space to injure something, and it is not to be thought of at all the way we would think of regular surgery or regular radiation. So this is sort of a diagram of how radiation might be thought of, where let's say this is at the middle of the radiation field, and we think of it in terms of isodose lines. In other words, how much radiation, let's say there's 90%, this is 90% isodose line, this is 50%, this is 10%, so that means the 10% is 1/5 the radiation of the 50%. So there are 3 key features to stereotactic radiosurgery. The first is that the radiation we're going to deliver is super conformal to what we want to treat. Now, if the thing we're treating is a circle or a sphere, this would be perfect. But again, it's going to be very conformal to what we want to treat. 2 is the radiation fall off is very, very fast. What we want is from the area of interest, let's say it's at the 50, is where the tumor is, we want the radiation to fall off very quickly, so there's almost no radiation within millimeters of our area of interest. And the third feature is that the treatment is going to be done in 1 and up to 5 sessions. There are different machines that can be used to do stereotactic radiosurgery. The most common types are probably the gamma knife, using gamma rays, and linear accelerators that are specially fitted for radiosurgery using X-rays, such as Novalis or CyberKnife. 99% of stereotactic radiosurgery is with gamma knife and Linac machines, and uses a technique called convergence of beams. So the way you're getting the hot spot at the area of interest, let's say it's a tumor, is by having hundreds of beams all focus on that spot. So if all the beams are coming into one spot, that spot is getting 200 beams worth, a lot of energy, whereas the areas around it are only getting a single beam. And that's how 99% of stereotactic brain radiosurgery is done. About 1% or less is done using these big, very expensive physics machines called cyclotrons. They have one at Harvard, they have one at Berkeley, they opened one in New Jersey. These are not clearly any better. Again, they're very expensive, very big machines that use proton beam is the most commonly used machine. And these can do stereotactic brain radiosurgery through a different technique using a physics concept of the Bragg peak. So these machines emit energy particles that are going to dump all of their energy, or almost all their energy, at a known distance from the emission point. So therefore, which is the Bragg peak. So therefore, if you put the target, if you put the tumor at that Bragg peak distance, at that distance that's where all the energy is going to dump, then you can again get a super highly focused amount of radiation right at that spot. Again, not clearly different, and this is again represents, I'd say, under 1% of stereotactic brain radiosurgery that's being done in this country. This is an example of a linear accelerator. And remember that most radiation that's delivered now, that's not radiosurgery, just standard external beam radiation, is done with linear accelerators that use X-rays. And there's no difference, by the way, between an X-ray and a gamma ray. I mean, 1 unit of X-ray is the same potency as 1 unit of gamma ray. But this is a standard linear accelerator that's going to swivel around, and little beams are going to come out. And some of the earlier plans for LINAC-based radiosurgery would involve several arc treatment plans. So this is an example of it's going to swivel around and shoot 5 arcs at a given target, and that's how it's going to deliver the treatment of interest. So here's another example of one of the earlier machines. And when I first came out here, we were using a LINAC-based system they had at North Shore called CyberKnife. And that was all they had out here. And I kind of lobbied and worked to get our Gamma Knife, which was the first one that we had on Long Island, which we opened about 16 years ago at South Nassau. And but this is what these earlier machines look like, and the person would be secured here. For most of the treatments, people are using head frames. Sometimes they're using very rigid face masks. Obviously, it's critical if you're giving this super focused dose during 30 minutes, 60 minutes, the head must be rigidly immobilized. So the person's going to be here, and then once everyone steps out, this machine is going to deliver whatever set treatment that we want it to deliver. And by the way, I'll also say the stereotactic brain radiosurgery, the team of people that are involved is a neurosurgeon, a radiation oncologist, and a physicist. For standard radiation delivery, it's just a radiation oncologist and physicist. As far as I'm concerned, the neurosurgeon's participation is critical. We're treating a lot of diseases that aren't, including a lot of benign disease that is not normally treated by radiation oncologists. We also have a sense of when does the person need surgery? What are the critical structures? There's a lot that we bring to the table, and I think it is critical that neurosurgeons be intimately involved and have a leadership role in brain radiosurgery. So this is a picture of one of the machines. We recently got a CyberKnife at Winthrop Hospital, NYU Winthrop Hospital. This is a linear accelerator that is hooked up to a robotic arm, and again has special software and hardware that's going to be able, unlike other linear accelerators, to deliver a radiosurgery treatment, a super focused treatment. So this would be an example of one of the earlier radiosurgery treatments. There would be a 4-arc treatment plan. This is kind of like an X-knife treatment that I might have done 19 years ago here. And it's able to deliver a very focused radiation dosage to this sphere. And here are the optic chiasm and eyes, and we can measure the treatment that's going to go to each. One of the problems with these earlier systems is, yes, you could generate a sphere of radiation that was very concentrated, but that might be good for a perfectly spherical brain metastasis, but a lot of things aren't perfect spheres. And some of the more complicated devices that we have, like Gamma Knife, are able to treat things that are much, in different shapes and sizes. So this was fine for, again, a single metastasis that was 1 centimeter perfectly spherical, but it was very limited for other things that I wanted to treat. The general categories of brain radiosurgery indications really fall into 3 categories. One is going to be tumors that are mostly going to be brain tumors. Could you theoretically treat a skull-base tumor, nasopharyngeal tumor? Yes, but it's going to be tumors. Vascular malformations, which is going to include arteriovenous malformations, AVMs, cavernous malformations, dural AVMs, and then a category called functional disorders, the biggest one of which is certainly trigeminal neuralgia, but let's call these diseases where the brain is going to be improved upon if we injure a part of the apparently normal part of the brain. This includes things like trigeminal neuralgia, glossopharyngeal neuralgia, epilepsy, movement disorders. This was a machine that we got originally here on Long Island about 16 years ago. This was the Gamma Knife, and one of the earlier designs here was where the person would be secured here, and then this was actually a big innovation at the time, this Model C, where this would automatically, there was a machine here that automatically moved the person to different isocenters. To make up a complicated shape, you might take an isocenter that looks like a sphere and then add a bunch of other isocenters that are spherical until you shape it into whatever size or shape you want it to be. But that allowed for much faster and more complicated treatment plans. And this is a picture of the person who's has their head frame on. This is the automated machinery and was about to go into the machine. This is a newer machine, newer version of the Gamma Knife. I think this is the Perfection. I mean, they keep having new machines. You'd think, well, Perfection, that would be the last one because it was perfect already, but apparently that was just the latest iteration. But I think our latest one is called the Perfection, that has all the moving parts on the inside, and here the only thing that moves is the table. And this is sort of the secret inner workings of how does the Gamma Knife do its magic. Well, there are like 200 cobalt sources that are always on emitting gamma rays, and the beams all focus on a center point. The Gamma Knife, which was really the first stereotactic brain radiosurgery machine, was invented by a Swedish neurosurgeon who's considered the father of radiosurgery, named Lars Leksell. And he was the reason he called it radiosurgery was he was trying to use radiation to do essentially what the surgeon would do without an actual knife. One of the limits, reason radiosurgery didn't take off until the last, let's say, 15, 20 years, it was very hard to see anything. Before you had CAT scans and particularly MRIs, even if you had this super focused technique, you didn't know what you were aiming at. So with the advance of MRIs in the 90s and better technology and better understanding of things, this really took off. Also, one of the issues before they had MRIs, the only thing you could really see well was brain AVMs, because you could shoot an angiogram, you had X-ray capability, and that's why a lot of the literature, the earliest radiosurgery literature, is on AVMs, not because they're the most common. In fact, they're now one of the lesser common indications for brain radiosurgery, but it was the only thing that could be seen at the time. So this is just a chart to compare stereotactic radiosurgery versus cranial or cerebral external beam radiation therapy, just to highlight what are the critical differences. So first of all, the action of brain radiosurgery is lesioning. It is injuring, and as such, it can be used on things that are benign, things that are normal structures like a normal temporal lobe or a normal thalamus or a normal trigeminal nerve. It gives enough radiation to a piece of tissue to damage that tissue regardless of what it is. Conventional external beam radiation works in a completely different manner, which is differential sensitivities. That is to say that it's mostly used on cancerous tumors, and the cancer cells are actively in division state, and when they're dividing, they are more susceptible to lethal damage from radiation, whereas most cells in the body are not actively dividing and therefore are not susceptible and not sensitive to that same dose. The target of radiosurgery can be, again, theoretically anything benign, malignant, a normal piece of tissue, whereas conventional radiation is used almost entirely on malignant tumors for the reason that it works through differential sensitivities. The area of radiosurgery is a relatively small area. In fact, we don't want any radiation, if we could help it, going to anything else. Whereas conventional radiation is typically to a large area. Most of the radiation is going to normal tissue. For example, the classic case of conventional radiation is whole brain radiation for multiple brain metastases. Most of the radiation is going to the rest of the brain, which is completely normal. But again, the theory is that the malignant metastases tumors are going to be differently sensitive to the radiation, and the normal brain is going to be less sensitive. Brain treated, again, the intent of radiosurgery is not to or to do minimal, whereas conventional radiation to the brain or any other body part, most of the radiation is going to normal tissue. Again, neurosurgeon is involved in stereotactic, but generally not for conventional. Cancer risk, that is to say, could there be secondary malignancy or other tumor that develops down the road as a result of the radiation? Again, for radiosurgery, very, very, very low, because the amount of tissue being treated is so small, but not zero, whereas conventional radiation, certainly we do see if the person lives long enough, like let's say you radiate a child or someone who's 20 or 30, even for something benign, and they live, there definitely is chance they will develop either benign or malignant tumors, depending on how long you look after the time of the radiation. So this is an example. This was not my case. I got this out of a textbook. I think this is from Pittsburgh. An example of a gamma knife treatment to a pineal region tumor. the key again, two of the key points I want to make from this. One is the shape of the tumor. This is a very irregularly shaped mass, and with Gamma Knife and with some of the modern radiosurgery techniques, we can contour the radiation to exactly what we want. We don't want this. A spherical treatment would be very unsatisfactory, and the hot spot might be twice what it is if we could be tight to the tumor and conform the radiation exactly to where the tumor is. So the first point is very conformal, irregular shaped tumor. And the other thing, which is a little harder to see, is that we're showing some of the isodose lines that the fall off is very rapid. Once you leave this, and Gamma Knife usually targets the 50% isodose line. Most linear accelerators target the fall off point, which is the targeting isodose line. The isodose line, you want to set it to where it's going to fall off most rapidly. For Linacs is usually the 80%. But so this is the 50% isodose line, and again, you want to see that the radiation falls off very quickly from there. So first I'm going to show you brain metastases, which is now the number one indication for brain radiosurgery. So brain metastases are common, and we're going to see them more as people live longer with cancer. And the issue with the brain, why it needs to be treated differently, is that the chemotherapy that does not get into the blood-brain barrier, and it can often be very excellent at controlling the systemic disease, but may not be so good for the brain disease. So we see more people with brain mets, and they can potentially live longer with control. The major categories we see is lung cancer, non-small cell, breast cancer, colon, sometimes melanoma, and renal. Not uncommonly, they will have a lot of surrounding brain edema. They are very irritating to the brain and can cause a lot of symptoms, even if the tumor itself is pretty small, like 1 or 2 centimeters. The initial treatment of these, the first discovery was that steroids added a little bit to people's lives, maybe extending life from 1 month to 2 months or something. Then there was a finding that if you gave whole brain radiation, that extended life for a few more months. Then there was a study that suggested that if there was a single brain metastasis, on the surface that you could surgically remove, that doing surgery for that followed by whole brain was a little bit better than whole brain, and those people lived a few more months. I think subsequently there have been studies where they've looked at, well, what if you just did radiosurgery? Now it's really the same thing as cutting it out. And I think the feeling is, and my feeling is, that Gamma Knife and brain radiosurgery is the treatment of choice for most brain metastases. I think if there is a big thing on the surface, they're herniating, there's a lot of midline shift, I think removing it is reasonable. I think if there's 50 brain metastases, whole brain is still good, but data really suggests that people do just as well, and it's a single treatment. They can get back to their chemotherapy. They don't have the debilitating effects, long-term effects of whole brain, which can include memory loss and other problems. It takes a month to do whole brain. So for most brain metastases, I'm doing radiosurgery as treatment of choice. I think a lot of people agree with that, and data bears out the benefits that, maybe not for 50 brain metastases, but for we're doing up to 10, and you can do them even in a single session with Gamma Knife. This is an example of a treatment before and after with an X-Knife, one of the earlier systems. And one of the things, and again, this is months later, you see the thing is totally gone. One thought is, well, if there's edema, is that a problem? But, we can put people on steroids, and the edema does not preclude us from doing treatment and getting a very good result. One of the key things, I think, with doing successful brain radiosurgery for the brain mets is getting them in immediately, because if you wait on this a month, this thing is now 3 times the size, and to then say, well, it didn't do well, of course, because you waited too long. So the timing is important. On malignant disease, I like to get them in like ASAP. I would just put this person on Decadron, get them in 2 weeks later and do it, and they'll probably do very well. This is a person, not my case, but this is a melanoma metastasis. And there's a preconception with standard radiation that certain things are radiosensitive, certain are radioresistant. And that's true when you're talking about standard radiation, because you're limited as to how much radiation you can give, how fast you can give it, because again, a lot of it's spraying into normal brain areas. So certain things are considered very radioresistant, like melanoma, cancer from the skin, metastases, renal cell, or sarcomas. Those tend to be not so responsive to standard. However, for radiosurgery, these are as responsive as anything, and they can do very, very well because, again, you're giving a lesioning dose, enough dose to make it disappear. And again, this is someone who had before and after a Gamma Knife a few months later. You see the melanoma has responded beautifully, and people with radio-resistant tumors are particularly good for Gamma Knife and for radiosurgery treatments. This is one of my patients we did with Gamma Knife. This is a lady who had non-small cell lung cancer, one of the most common things we see. And when I talk to different populations, I always tell them, you can prevent brain cancer, because the most common brain cancer is from smoking. It's from lung cancer. So brain cancer is preventable. Brain tumors are preventable. And I, particularly whatever, the kids, they start with the juuling and they say, that's nothing. But I'm like, all right, but you're a good chance you're going to end up smoking. This is not a good idea. We see it, this is one of the most common reasons we're called in for brain tumor is smoking. So this is a lady who had 3 brain metastases from non-small cell lung cancer. There were 2 here, 1 here. We put her in for Gamma Knife, a single session, and the tumors disappeared. This is an MRI of her 6 years later. I mean, she had well-controlled systemic disease. Now, obviously, Gamma Knife can only control the brain disease. If they have uncontrolled systemic disease, you can't do anything about that. But more and more, the systemic control is getting better with better chemotherapy, and she did beautifully. And again, I mean, 6 years later, still had no recurrence. We follow them every few months to make sure that these or other spots are not developing again. So most malignant brain tumors we're treating are brain metastases. The other major category of malignant tumors in the brain is gliomas, the tumors that arise from the supporting tissue, the glial cells in the brain. The issue with the gliomas, and these are often not so great for radiosurgery, is they're often diffuse disease. I mean, or poorly defined. So sometimes it can be considered. I think for a lot of these, we're usually removing them as much as we can if possible, and you're going to usually look to give a wider field radiation afterwards because there's spots of tumor all over the place. I mean, they've done autopsy studies of people with glioblastoma, for example, and they always find glioblastoma cells all over the brain, and even if it was the smallest, most superficial tumor that you saw, and that's why you can never cure a glioblastoma with a knife. Because even if you give a huge margin, it always comes back because it's a diffuse disease, and radiosurgery is good for local focused diseases, but sometimes there are some focal components, like a glioblastoma that recurs there's a small area of enhancement that recurs. We could do radiosurgery, for that. This is an example, not mine, of a person who had a low-grade glioma, a child in the brainstem. Again, going to be difficult, risky to operate on. And sometimes the lower-grade gliomas, if they're not too big, are somewhat contained and focal. This person did have Gamma Knife and it shrank, and they did very well and had a nice response. So there are some gliomas in some cases where radiosurgery has a role, but again, it depends on where is it, what's the size, can we safely remove it or not. So next I'm going to go into benign brain tumors. The 3 common benign brain tumors that we see are acoustic neuromas, meningiomas, and pituitary tumors, and these are all very good for radiosurgery. So the first I'm going to talk about is acoustic neuroma. When I trained, I mean, these all got operated on, whether they were big, they were small, whether they were minuscule. I mean, it was just considered that was the way to go. As far as I'm concerned, I feel that the gold standard for acoustic neuromas right now is radiosurgery, is Gamma Knife, unless it's enormous, or it's minuscule and stable over the years. So acoustic neuromas are benign tumors that arise from the 8th cranial nerve. People often present with decreased hearing, dizziness, balance problems. We're finding them earlier and earlier because there's an MRI on every block. So anyone has the slightest symptom, my hearing's 1% less, they get an MRI and we find it. So and that is more favorable for radiosurgery. The surgery itself, again, can be done, but there's at least a 1% chance of death from the operation itself, a high chance of losing hearing, a high chance of facial weakness, particularly if the tumor is big, a certain chance of stroke, of meningitis, which you really hardly have any of that with radiosurgery. So standard radiosurgery, what we'll often see is, this is a person who had acoustic, had Gamma Knife. You'll often see 6 months later, 12 months later, some central necrosis. It could look a little bit bigger, and then here it shrinks down. Now, people who, I guess, want to operate on these, the things I've heard them say is like, well, you don't want to live your life with that in your head, but the truth is, like, who cares? I mean, if it's inactive, dead scar tissue that's not bothering anybody, I don't know why that would dissuade somebody. And the other argument I've had is people who want to remove these say, well, you don't want cancer. Well, no, of course you don't want cancer, but the chance of you getting cancer from Gamma Knife might be 1 in 100,000, it's a minuscule amount. And so the likelihood you're going to die of cancer from Gamma Knife or an acoustic is minuscule, whereas the chance that you're going to die from a brain operation is like 1 in 100. There's a real chance of something seriously bad happening. And I'll tell you also, there's a lot of bad things that happen from surgery that aren't even included in the statistics. I'll see someone who has a suboccipital craniectomy, and then they have severe intractable pain in the back of the head that never goes away. And that won't even be included as a complication. That's like, oh, well, that's nothing. But so surgery is a serious thing. These people do great with radiosurgery. And again, almost all of them I'm doing Gamma Knife on. If the tumor's enormous, I believe, and I think a lot of people are now saying, just debulk it. Don't scrape it off the nerves. That's where all the complications arise from, and do Gamma Knife on the residual. Also, I would say we're quoting for results with the new dosing that the lower dosing for Gamma Knife. The facial weakness almost never happens. I've done over 100 Gamma Knife just for acoustic. I've never had anyone with any facial weakness. I had one person who had the most minimal amount for like 3 weeks and it went away. And as far as hearing preservation, it's about 60 to 70% of what it is going into the treatment. So if they have no hearing coming in, they're not going to have it afterwards. But if they have good hearing coming in, there's a good chance that they will preserve the hearing at the level that they come in with. And that's one reason to consider Gamma Knife earlier rather than later, is because it's unpredictable. How will the hearing deteriorate over time? Sometimes it's sudden, or you wait a bit and it deteriorates, and then you can't really get it back. Or it's hard to get back. So this is one of our earlier cases, and again showing 50%, 40%, 30% isos line. Just the point to see how conformal we can make the treatments, how the dosage rapidly falls off. This is some other acoustic case of mine. This is a lady we treated 15 years ago. She had partial decreased hearing, and we did Gamma Knife on her. This is at treatment. This is 15 years later. The tumor is stable. Her hearing is exactly where it was 15 years ago. She did beautifully. This is another treatment. This is a patient I treated. This was about 7 years ago. She presented with a little decreased hearing, a little dizziness. We minor stuff. We treated her. Again, 6 years later, tumor is much smaller. Her hearing did get a little bit worse, but she still has serviceable hearing. She did beautifully. There's another patient that I treated. Patient with neurofibromatosis type 2. Most of the patients we see are just single acoustics. There's no genetic or family predisposition. In rare cases, we'll see people with NF2. These are a little more complicated because obviously if you lose hearing in both ears, you've got a devastating problem. She presented with some headache, she had 80% loss of hearing in this ear. We treated this tumor, and this was several years later, the tumor is almost completely gone, and her hearing is almost back to normal in this ear. Now, this tumor was getting a little bit bigger, and we recently treated the left side tumor, but she did beautifully. And again, I think Gamma Knife and radiosurgery is a beautiful way to treat a lot of people with NF2 who have a lot of tumors, and it's pretty morbid, and the way it was used to be treated, where every single tumor got removed, and this young woman did beautifully. So this is the next category of benign diseases, meningiomas. And again, certainly somebody who has a 7-centimeter tumor with shift and they're herniated, of course you're going to operate on them. But a lot of these we're finding smaller, it's not too big. And one of the key features about radiosurgery, when I say, is it a who, what, when, where, why, it's a when. What is the time frame in which you got to take care of this problem? If you have time, you can do a lot of things with radiosurgery. If someone's got a hydrocephalus, they're herniating, this is not something that's going to fix something tomorrow. So if you need relief tomorrow, then you got to do an operation. But if you have time, this is a beautiful way to go. This guy had an incidental meningioma that was found to be getting bigger over time. Here's some pre-op pictures. We did Gamma Knife on him. This was several years later, and you could see the tumor's almost completely gone. He did great. And again, could one have removed it? Could you have gotten in trouble with the motor area or the superior sagittal sinus? He did very nicely. And meningioma's a benign tumor, not typically treated with standard radiation, but can do beautifully with radiosurgery or Gamma Knife. There's another lady who had a meningioma. And again, most of the people, we do not do biopsies. Most of them, we assume it's a tumor. We assume what it is. This appeared to be a convexing meningioma. This was a 67-year-old physician who came and said, hey, I have this. And it was being followed. It was getting bigger. Some nonspecific headache. I don't feel exactly right. Not much edema around it. So we thought it was a meningioma. And we said, okay, well, most people probably take it out. Radiosurgery is an option. But, I suggested let's just take it out. She said, let's do radiosurgery. And I don't know. She said, because she had done her research. So we said, okay, because it was a bit bigger, we did a Novalis treatment. We did it over 5 sessions. And I think, one of the ways of dealing with things that are bigger or near sensitive areas is to either give a lower dose or give over or fractionate it, like give it over 5 sessions, or even stage it. You can treat part of the tumor today, part of it 6 months from now. So we did a Novalis for her. This was a few years ago. And here the tumor shrank. She's great. It didn't blink an eye. Is very happy with things. Could she have done a craniotomy? Yes. But there's always risk. Could there be infection? Could be, seizures. She did great, never had any problems, and was very happy. So the third category of benign tumors that we commonly see, and obviously there's a whole bunch of very rare problems, is pituitary tumors. So these come in 2 categories. There's the secretory, non-secretory. The secretory, there's the prolactinomas, the acromegaly cases, and the Cushing's, and the non-secretory is not secret, not producing excess of anything. If the tumor is secretory, if they're prolactinomas, almost all of these are treated with medicines, cabergoline, bromocriptine, and they do almost always fine. Unless there's a bleed or a giant cyst, most of them I just follow and I say I defer to my endocrine colleagues. When it's acromegaly or Cushing's, usually the feeling is we should do transsphenoidal, and we usually do endoscopic transsphenoidal through the nostrils because there's a chance of curing them at surgery, and I think the transsphenoidal is a very low-risk brain operation. However, I think for those patients with acromegaly Cushing's that you've operated on and you couldn't get all of it out, radiosurgery is a very nice way to go. You tend to give a higher dose than if it was a non-secretory tumor. For the non-secretory tumors, if they're, again, big, causing optic nerve compression symptoms, we'll often operate first. But again, radiosurgery is nice for recurrences or residuals, and it's also good if the tumor is not really pressing much on the chiasm or if the person has medical problems. So this is an example. This is one of my cases. This is a guy we did a transsphenoidal on 3 years prior to this, and he did really well from that, and it looked like all the tumor was gone and he was doing beautifully. And I always follow these people because I'd rather find out if this tumor coming back when it's not too enormous than if they're having severe neurological symptoms. And we followed him, and 3 years later, lo and behold, there was definitely recurring tumor developing. So I said, okay, let's do Gamma Knife. And again, I like Gamma Knife as a follow-up. I think transsphenoidal is nice to do once. I don't generally think it's great to be doing over and over and over again. We did Gamma Knife, and here's a few years later, you see the tumor did beautifully. It's all gone, disappeared. I think he's on Synthroid, otherwise hormonally doing great, did very nicely. This is not my case, this is a Pittsburgh case, but someone who had a benign pineal tumor. I don't even think they biopsied it, but again, they felt based on markers, everything was benign tumor. It would have been complicated to remove. They did Gamma Knife, and lo and behold, it disappeared. I think you want to be confident, or pretty confident that, that you're dealing with a tumor and not, just some other abnormal finding. But you do not necessarily have to biopsy. And again, it depends on the case. What's the risk of doing that or not? So the second category of brain radiosurgery cases is vascular malformations. And again, it used to be, if you look at the literature, most of the radiosurgery literature was on AVMs because it was the only thing you could see and target. So the AVMs, the risk is thought to be about 3 to 4% per year of bleeding. About half of those are going to be catastrophic. They can also present with seizures, and they can also have some headaches. Sometimes they have associated aneurysms. If you treat the AVM and it's gone completely, often the seizures will go away. Often the risk of bleeding can go to 0, and often the associated aneurysms will often go away as well. These are high risk to remove. Also, I think right after a bleed of a standard brain AVM, it's about 6% the first year after a bleed, then goes back to 3%. Gamma Knife, magically, when aimed at this is an angiogram, when aimed at the abnormal blood vessels of an AVM, causes them to thrombose and no longer be a risk for bleeding. This is not my case. Gamma Knife before, And this is after an angiogram a few years later showing the thing is completely gone. The beauty of it is that the dose that we use for radiosurgery for AVMs does not cause thrombosis of the normal blood vessels, which is critical for us. So that's a magical and wonderful thing that helps us, that helps us. Evidence does not support doing embolization on these before Gamma Knife. So the only time I remove, my algorithm, most AVMs, to me, this is the treatment of choice. If the AVM is small and bled and the person's young and it's on the surface of the frontal lobe, then I'll embolize and take it out. Otherwise, this is the way to go. If the AVM is enormous and taking up half the brain hemisphere, I leave it alone. Otherwise, this is a way to go. Often the nidus is a lot smaller than what you think it is. People are often looking at draining veins and other things. They're like, oh, it's too big, but often is not and is easily treated. There's a lady we did treat with, she had ruptured her AVM when she was pregnant. We let her deliver, and then we did a Gamma Knife. Again, a very irregular looking AVM in the vermis of the cerebellum. And again, this is just to show you that we're able to contour exactly to the nidus, exactly to what we want to treat. This is one of my cases also. So this is a child, and one of the few cases of children that we do Gamma Knife and radiosurgery on is for AVMs, because that's one of the things that if a kid has an AVM, you're going to want to treat it, but you may not want to operate on it. And this child was 13, had some little symptoms on the right side. Right side wasn't exactly right, maybe a little headache, dizziness, not too much, and had this AVM and a bit of a moya picture as well. And we did a Gamma Knife on it. And this was a few years later, and again, I would say, looks beautiful. You can't even tell there was an AVM. It looks completely normal. To me, these operations are fraught with disaster. Even when it looks like it's not going to be so difficult, it turns out to be often a lot more difficult. There's more bleeding and more morbidity. The other thing I'll mention is, cavernous malformations. Again, we see these a lot less commonly than a brain. This can work also for dural AVMs. Or CC fistulas if you couldn't, treat it with neurointerventional. But also cavernous malformations can also be treated. Again, these usually we leave alone. If they bleed, then I think they can be considered for treatment. The problem, we could remove them, but the problem is that they're often in the brainstem or basal ganglia, and if they're in an area where they have symptoms and it would be hard to remove because of high morbidity, Gamma Knife, even at very low doses like 11 gray, 12 gray, can be protective against further bleeding, and we would consider doing that. So the last category of indications is functional. And again, some of the categories of treatment, the biggest one is certainly trigeminal neuralgia, where people get sudden, sharp, severe electric shock pains in the face, usually caused by arterial compression of the root of the trigeminal nerve from the superior cerebellar artery. Could be another artery, could be a vein. Also can be caused by MS, and in rare cases by a tumor. Glossopharyngeal neuralgia, and with one of the treatments of trigeminal neuralgia, one treatment is to move the artery away. One treatment is to put a needle in the cheek and injure the nerve a bit. Because we've found that if you injure the sensory fibers a bit, you can disrupt the pain signal. The pain requires a sensory input, like a light wind. You touch the face, a sensory signal goes up the trigeminal nerve root, and then because of the arterial compression or the MS, it misfires and then jumps onto a pain fiber, the fiber that would have registered if you stuck your face in an electric socket. So then it continues traveling to the brain as if you got an electric shock, but to start the pattern off, you need a sensory input. So by injuring the sensory fibers, you can disrupt that. One way is by putting a needle in the cheek, putting it through the foramina valley, and injuring the nerve a bit with radiofrequency or glycerol. But another way is to aim the radiation on the trigeminal nerve root, and that can also do the job. Glossopharyngeal neuralgia is a disease like trigeminal neuralgia, much less common, where people get sudden, sharp electric shock pains in the distribution of the 9th or 10th cranial nerve, so they get pain in the deep ear or deep throat. Also usually responds to Tegretol or anti-seizure medicines, but if that fails, then again, cutting the 9th or 10th nerve can be effective, and Gamma Knife, where we injure the nerve with a focused radiation, can also work. Tremor is another indication. We hardly ever do this. Again, tremor, more like essential tremor. It's been found that if you injure one of the nuclei of the thalamus, you can disrupt the pain signal. So again, people with Parkinson's are usually not such good candidates for this because they often have a lot more going on than tremor. And even people with essential tremor, often it's bilateral, and that makes it more complicated. But if you had essential tremor and is mostly on one side, injuring this nucleus could improve your situation. One can do this with surgery, putting a needle in here, or one can do it with deep brain stimulation. Michael J. Fox had Parkinson's, and they did a thalamotomy to alleviate his tremor. They put a needle into his head and injured this nucleus. It can be done. If a person's not a good candidate for those things, one can do Gamma Knife and aim it right on that nucleus and improve the tremor. It could take several months. I mean, if one had it bilateral, you could wait a year or two and then do the other side. Again, I would say we don't do too much of this, and often people are going for deep brain stimulation for this. This is an example of Gamma Knife for epilepsy, for medial temporal lobe epilepsy. Again, there were studies done on this, and I think this has not really taken off so much, and the problem is it's a big area. You often have to get a lot of necrosis, and people are now looking at other treatments like the LIT treatment, where they do some other minimally invasive needle-based injury to the temporal lobe, or just do a standard temporal lobectomy. But this was thought as an idea, but again, we're not really doing too much radiosurgery-based movement disorder and not much epilepsy at all. Trigeminal neuralgia, however, we're doing quite a bit of, and for people who are, either they've had an MVD already, or they're elderly, a lot of these people are older, or they have MS, Gamma Knife can be very effective. This is one of the earlier patients we had his neurologist had tried like 6 different seizure medicines. The person was just in agony for years, and finally found out about us. We did a Gamma Knife treatment, and within like 3 weeks, the person's pain was gone. They did beautifully. I don't feel you need to try someone on 6 different medicines. Usually for me, it's Tegretol and gabapentin, and that's it. I mean, if you're failing those two, if somebody wants to keep trying every other seizure medicine, but those are usually the best. But I'll say that nowadays we're usually treating a little bit more distally on the nerve, but this person did really well. This is another person that I recently saw in the office this past year. He had bad left-sided trigeminal neuralgia, V2, failed medical and conservative measures. He had like heart stents and heart operations. He was, I think, 64 at the time, or in his 60s, and I recently saw him. He's 15 years out, coming to see me for something else. I said, "How's your face, man?" He's like, "That's gone." And he's on no medicines, and people can do really nicely. And this is, again, showing this is super magnified view. We can see the nerve beautifully. This is another lady who had multiple sclerosis, and about 2% of people with MS have trigeminal neuralgia, and you're not going to do an MVD for them because the presumptive cause is not an artery. And we did a treatment for her. She failed her, I always try medicine first, conservative first. We did this. She got relief for a year, and then we brought her back, and we did another treatment a little further down on the nerve, a lower dose, and then she's been good now. It's been 6 or 7 years since her last treatment. This is not my case, but showing an example of how you can have bigger targets. This is somebody who has a very big meningioma, and they'll say, "Oh, well, if it's big, then you can't." But you can do radiosurgery. The question is, how long do you have to treat it? And this person had a staged treatment, so part of it was treated in one session, and then then that went away. Then maybe 6 months later, they did another session, and ultimately the thing shrank significantly. The person did fine. So, in summary, there are a lot of myths about what is radiosurgery, what can be done. And the myths, for whatever reason, are just all over the place. Like just 2 weeks ago, I met a medical oncologist, and I said, "Where do you send your brain metastases for radiosurgery?" She's like, "Radiosurgery? I send them for whole brain radiation." I'm like, "Why? Like, what? No one's doing that, But who knows? I don't know what the myth, but so first of all, it can be used for adults or children. Certainly most of the treatments are in adults, but children that are appropriate, like the deep AVM that bled, would be reasonable. Targets mostly are small or medium, but large targets can be considered depending on the case. How difficult would it be to remove? That meningioma I showed you, probably would have been pretty hard to excise it from the cavernous sinus and the eye socket and the carotid artery. It can be done intracerebral or extracerebral. Certainly most of the brain things are intracerebral, but there are things that we sometimes see skull-based that can be treated. They can be done with or without surgery. Certainly we want to have some idea what it is, but most of, if you look at AVM, acoustic, trigeminal, pituitary tumor, most of these we have a pretty good sense what it is, and you don't necessarily have to do a biopsy or cut it out first to do it. They can be done with or without conventional radiation. So, again, sometimes there would be reason to mix in whole brain, mix in standard radiation, but sometimes this is standalone and is perfectly fine. It can also be done with or without chemotherapy. You don't necessarily need chemo for that or for anything else in order to do that particular treatment. It can certainly be done for malignant or benign things. People, again, a lot of people stuck on this. Well, it's only good for cancer, but this won't work for anything that's not cancer. Completely untrue. It can be done for things that are single or multiple. We can, we treat multiple lesions, no problem. Treat 5 Mets at a single time, 8 Mets at a single time. It can be done with or without edema. Now, again, if there's uncontrolled edema, the person's herniating on 4q6-decadron, sure, you wouldn't do that. But again, the edema, if it's controlled, it can be done. You can do, again, with or without tissue, so long as you have some reasonable idea what it is. And it can be deep or superficial, or both totally fine. This is an old slide I had when we got our Gamma Knife in '98. So this was '99. I had this first slide. But it's still worthwhile in that it shows you how this has really taken off. The radiosurgery capability, there are a lot of hospitals that now have capacity to do these kind of treatments, which are really much, much better for patients in certain circumstances. And again, a lot of it is, MRIs took off in the 90s. These machines became available. It became more accessible. But before I came here, there was, again, this one X knife that we could barely do anything on. Now we can really treat people, and the good thing is the gamma beams are always on. So like there's always time. There's never an issue with block time. Like if I want to do 3 cases tomorrow, I can do. There's always time to do it. So anyway, so thank you very much. I think this is an exciting development, and just something to keep in mind for neurosurgeons for our armamentarium. Thank you.